In this video, we will be discussing about thrombotic microangiopathy or TMA. Right. See, TMA is characterized by a triad of three things. One is MAHA, microangiopathic hemolytic anemia. Second is thrombocytopenia, and third is end organ damage. End organ damage is in the form of raised markers of end organ damage, like we can see it in the form of increased serum creat, increased LDH, increased AST or ALT, right, or increased cardiac troponins, and many other markers, right. MAHA. How to diagnose MAHA? Microangiopathic hemolytic anemia. There are schistocytes, the most important marker. Schistocytes in peripheral blood film means there is some damage to erythrocytes when they pass through microvessels. So the resultant RBCs, the form of RBCs is called schistocytes. Increased LDH, increased heptoglobin, normal PT or PTT, fibrinogen will be normal, means there is no coagulation, means excessive coagulation is not there. It is purely a disease of platelets. Direct sputum test will be negative, means no autoimmunity is involved. So this is microangiopathic hemolytic anemia. The disorder pertains exclusively to the vascular cause. That's it. Without any involvement of immunity, without any involvement of any other mechanism. Biopsy. We will see arterioles which are filled with platelets and hyaline thrombi. Right. This is the biopsy finding. Very important. See, we have to rule out the secondary causes of thrombotic microangiopathy also, like DIC, vasculitis, malignant hypertension, preeclampsia, HELP syndrome, drugs, etc. How to rule out secondary causes? It is by taking proper history, drug history. If there is pregnancy, you will suspect preeclampsia or HELP. If there is malignant hypertension, you will see corresponding signs and symptoms like retinopathy also, and organ damage also, right. Vasculitis, you will see particular antibodies which pertain to some sort of vasculitis. Then DIC, in DIC there will be elevated fibrinogen, there will be decreased fibrinogen and elevated products of fibrin degradation like D-dimers will be elevated in DIC, though all other features will be similar as of TMA, but a few one or two markers we need to do to rule out secondary causes. Now there are two types of thrombotic microangiopathies. One is HUS and second is TTP. HUS and TTP. What is HUS? Hemolytic-uremic syndrome. What is the mechanism? Two mechanisms. One is Shiga toxin related and second is complement dysregulation के कारण. Shiga toxin means Shiga is a Shigella shigi is a bacteria, gram-negative coliform bacteria which causes bloody diarrhea in children. So any child coming to you with history of bloody diarrhea, with AKI, with anemia, with thrombocytopenia, you will suspect hemolytic-uremic syndrome in that patient. Mechanism is Shiga toxin will cause damage to the renal endothelium. There will be intrarenal thrombi which will form. There will be ischemic damage to the nephrons or kidney as a whole, which will cause AKI. Complement dysregulation can be inherited, can be acquired. There is complement mediated damage to the glomerulus, and there is complement mediated damage to the platelets, right, that will cause thrombocytopenia. So HU is a cause of thrombocytopenia. What is the treatment of HUS? See, platelets are contraindicated, though to overcome the acute episode of bleeding we can transfuse platelets, but Platelet transfusion is not the treatment at all. So platelets are mostly contraindicated until unless there is severe bleeding. If there is Shiga toxin related HUS, we have to give supportive care, like take care of the dehydration, take care of the nutrition, take care of the fever, take care of the pain or abdominal crampy pain. Uh, as soon as Shiga toxin is cleared, things will come back to normal. If there is complement dysregulation, see, it can be acquired, it can be inherited. Complement is dysregulated, we will have to do plasma exchange along with eculizumab. What is eculizumab? It is complement C5a inhibitor, means activated complement 5 inhibitor. It will prevent the formation of membrane attack complex, right? So eculizumab is given along with plasma exchange to control the complement. So this is all about HUS. Now TTP, thrombotic thrombocytopenic purpura. It is mostly a hereditary condition, inherited condition, in which there is decreased ADAM-TS13 activity. What is ADAM-TS13? It is a matrix metalloproteinase, MMP, which degrades von Willebrand factor. Right? See, if von Willebrand factor is not degraded, multimers of von Willebrand factor is the activated form of von Willebrand factor. It needs to be degraded rapidly to its monomeric form so that there is no excessive platelet activation. But if there is decreased ADAM-TS13 activity, there will be persistence of large VWF multimers on endothelial surface, and there will be excessive platelet adhesion and trapping and activation. It will cause thrombosis, right? Excessive use of of platelets will cause thrombosis, and it will result in thrombocytopenia, right? Clinically, there will be a pentad of thrombocytopenia, microangiopathic hemolytic anemia, altered mental status, renal failure, and fever, right? What is the treatment? We have to do plasma exchange rapidly to remove the excessive, von Willebrand factor, multimers of von Willebrand factor. Plasma exchange along with immunosuppression if required, along with rituximab if required. It is always plus minus. What if plasma exchange is not available? We can give FFP, right? What is there in FFP? There is fresh ADAM-TS13, which is present in FFP. It will break down the VWF multimers, right? It will serve the purpose of plasma exchange, though it is a temporary measure. Platelets are obviously contraindicated in TTP. So any cause of TMA, primary TMA, whether it is TTP or HUS, platelets are contraindicated, right? So this is all about thrombotic microangiopathy, which needs to be remembered. Yeah, that's all. Thank you for your patient listening.